Okay, I think that's fine. Um, one of the admins just laughed at me, so that's great. Okay, I think all the audio stuff should be fine, so I'm just gonna get started with passmed. 64-year-old man, GP, 64 GP, deteriorating breathlessness, 2 months. Got the Sabah. God, what's this? No work? No? We've got dry cough, worse in the morning, before bedtime, no fever. Corazol, what does corazol mean? Oh, like the cold, okay. 94 sats. It's got background COPD. His peak flow is fluctuating, so it matches up the breathlessness in the... Oh no, the dry cough in the morning and the night, okay. So he's on the SABA already, so I don't think you switch anything. I think we're only going to be adding LABA ICS. I don't think we do ICS yet. I think it's that one. Oh, okay. But how does it... okay, fine. No, fine, completely fair. Right, okay, so the patient... Okay, we got it wrong, obviously. Poorly controlled COPD, clinical history, suggested what? So the clinical history suggested... The perf diary suggested diurnal variation in symptoms. So in these patients, asthma, nice recommend features of asthma. In patients with COPD who fail to improve with the SABA, or a SAMA, what's an example of a SAMA? Oh god. Ipratropium. Okay. Okay. Features of asthma should be treated with the SABA, LABA, ICS. SABA, LABA, ICS. And then if they fail to improve, we'll throw on the LAMA. Okay. SABA, a LABA, and a LAMA. If patients don't respond to this regime, trial period of SABA, LABA, LAMA, and an ICS can be offered for 3 months. SABA and a LAMA. So SABA and a LAMA is not a step in the management of COPD. COPD, COPD, whatever. I haven't got like a chat open, so I don't know if anyone's actually saying anything. You should check. Oh right, no. Oh, there's two. There's two of you here. Oh, very funny. Okay. Somewhere here I'm supposed to be able to pull out a chat, but whatever. Shall I open somewhere else? God, that phone is quite hot. It's probably fine. Hey Oasis, how are you? Good? Good. Can I just bring this chat out? No, maybe not. Okay, whatever. Okay, right, so COPD, we are going to... We may as well just read the textbook at this rate. That's what we're going to do with resp in it. So... Resp. So basically, for the way that I'm studying, these are all the conditions I'm concerned about. So if we just look at the big picture, I suppose the way that I study you can apply to whatever you do. So acute bronchitis, allergic disorder, so all of this. Asbestos, and asbestos like causes mesothelioma, I believe. Asthma is a big one. Asthma COPD overlap. Bronchiectasis is the one with like the really purulent, like the smelly sputum, I think, anyway. Bronchiolitis, so that's like RSV bronchiolitis. You see that in GP a lot. COPD. I keep saying COPD, I feel like it's because I'm on stream, but I always say COPD COPD. Cystic fibrosis, fine. Fibrotic lung disease, fine. Lower RTI, fine. Lung cancer, fine. Occupational lung disease, silicosis, yeah. Pneumonia, pneumothorax. Oh, pulmonary arterial hypertension. You give Viagra for pulmonary arterial hypertension, I think, anyway. Pulmonary embolism, resp failure, sarcoidosis, tuberculosis, and viral upper RTI. So we'll read the notes for these, and we'll see how it is. Or we could do questions. We should jump into questions. Those are the conditions I need to know, basically. But I tell you what, we'll do cardio. No, we'll just do resp. Okay, we're just going to do resp. And I think we'll put the MLA filter on. Okay, right, let's go again. Okay, fine. So 19-year-old female, ED, chest tightness, SOB, shortness of breath is SOB. She's drowsy, confused, unable to give a clear history, but from her records you can see she has a history of asthma. She has a SABA and her blue and brown inhalers she uses. There's a widespread wheeze, 94%, so that's bad, obviously. She's breathing at 28 beats per minute, 120 heart rate, temperature's normal, and she's hemodynamically stable as well. No bleeds or anything, she's got normal blood pressure. Her peak is 35% of predicted, so I think that's like very bad. If you're only able to expire 35% of what you're supposed to be, it's not good. I think it was the Ninja Nerd video actually said, like, if you want to feel what it's like to have asthma, what you should do is take a deep breath in, and then take a deep breath in, hold it, and then try and take another deep breath in, and then you keep trying to do that, and that feeling of like not being able to breathe is what asthma feels like, basically. She's unable to give a clear history, so she's drowsy and confused, unable to give a clear history, and so her pH is fine, her PCO2 is fine, and her oxygen is fine, but I think the fact that, I don't know if it's like the saturations or the fact that she can't actually give the clear history, like she's not able to speak in proper sentences, so I think it would be like severe or life-threatening, but it's obviously quite bad, so it's not mild or moderate. Severe, life-threatening, or near-fatal? I don't think it's near-fatal. Severe? Oh, okay, fine. 50-50 in it, 50-50. Oh, confusion is a life-threatening feature. Okay, fine. Right, yeah. Well, missed that out, didn't we? So mild is not a real thing. If she has any of the criteria for life-threatening asthma, so it'll go through here anyway. And near-fatal is not right. What do the comments say? How did she manage a peak flow when... Life-threatening features. What? The comments, that you can literally learn so much from the comment section sometimes. I learned quite a few mnemonics from it. Okay, right, so let's go through this. So the asthma attack is life-threatening. Okay, why is it life-threatening? So why is it not severe? So she has some features of severe asthma attack. So perf is 33 to 55. So it is definitely like, it meets the criteria to be severe, but because she has confusion and her CO2 is normal, it would be classified as life-threatening, but yeah. So acute asthma. BTS classifies patient with acute asthma into moderate, severe, or life-threatening categories. Can I get speechify to speak this. Will it speak it?
Note that a patient having any one of the life-threatening features should be treated as having a life-threatening attack. A fourth category, near-fatal asthma, is also recognized characterized by A, raised PC, and/or requiring mechanical ventilation with raised inflation pressures. Further assessment. The BTS guidelines recommend arterial blood gases for patients with oxygen sats lieutenant. 92% at chest X-ray is not routinely recommended unless life-threatening asthma suspected pneumothorax failure to respond.
To treatment, right? Okay. So moderate is where your perf is like 50 to 70% best or predicted. The speech is normal. So obviously here she couldn't complete the sentences in this stem. So yeah, let's check the chat. See if there's anything interesting happening. Hi Nick, might as well sit and revise. Oh yeah, of course. Why not? Lovely to have you here. Love you guys so much. Love you all. Okay. So near fatal asthma is a thing. It's also recognized characterized by raised PCO2. Okay, so how are we gonna manage like how are we gonna manage an asthma attack basically? So all patients with life-threatening asthma attacks should be admitted into hospital. The patients with features of severe acute asthma should also be admitted if they fail to respond to initial treatment. Other admission criteria include a previous near-fatal asthma attack. If the patient is pregnant, or if an attack is occurring despite already using oral pred. So corticosteroid prednisolone is like the most common one you see. I don't think you give Dex. I think pred is like the main one. I don't know why. It's like the glucocorticomineralocorticoid effect of it is like balanced or something. You know what? Let's check. Let's check ChatGPT. God, I hope my chats don't come up in here. Let's shut that. Why do we give pred for asthma and not Dex? Okay, so pred has a shorter half-life. Evidence and tradition. I don't know what USERs are. So Dex tastes better, so it's easier for the kids. Right, interesting. Yeah, I mean we give pred. I don't know why. Specifically, but here it talks about the short half-life, maybe, probably. Let's check PubMed. Dex versus prednisone versus prednisolone for acute peds asthma exacerbation meta-analyses. What were the results? So basically, the study concluded dexamethasone is a suitable alternative to pred for pediatric asthma exacerbation. Was there anything else? Oh, that's peds. Is that like a normal one? Children. What in adults? I'm sorry, I'm going on a tangent, but all of this is in peds. Why is there no studies in adults? What are the results here? Okay, so both adults and children. So basically here there was no difference. Okay, but for some reason we give pred. Don't know the exact reason though. There you are. Okay, so oxygen, if the patients are hypoxemic, which means that there's low oxygen saturations, it's important to start them on supplemental oxygen therapy. So again, it always comes back to if you have like a patient with, symptoms and you're quite worried about them, always make sure you start off with your basic obs. In the situation, what are like some things we can do? We can take the temperature, take the pulse, check the oxygen saturations, take a blood pressure, assess them, look at them, and you do your whole A to E exam. So what's A to E? Airway, breathing, circulation, disability, and everything else, I think, is E. So, look at them. Are they talking? Is the airway patent? Breathing, how are they breathing? Is there equal chest expansion? Circulation, check the pulse, check this pulse, check that pulse, count the heart rate, do the capillary refill test. So capillary refill test, you'll hear cap refill, is basically where, let me show you. Basically, let me make this a bit bigger. Capillary refill is basically where you're going to so they'll put the finger out and then you're basically going to hold and then watch my finger, it'll turn white and then you see the blood refills. So do this and we're checking for distributive shock, I think it is. We're checking something, right? Where if the circulation is impeded, that will be prolonged. The normal reference range is less than 2 seconds. So you hold it there. And then, wait, why is the thing flashing like that? Oh, okay. I just want to make sure it's not like that on the stream. Let's check. Oh, it is. That's so embarrassing, man. Let me go and turn the light on, actually. I think that should be fine. There we go. I kind of don't like that. You know what it is? It's like a dodgy lamp. I should just get a new lamp in it. Should we go lamp shopping? Nah, lock in. Lock in. Okay. Where was I? Oh, right, yeah. So, capillary refill. So, like that. And then it'll go white. And then do you see it goes red again? So that should be less than 2 seconds. And that's normal. Oh yeah, you guys are both revising. Yeah, wicked. Right, okay. If the patients are acutely unwell, it should be started on 15 litres of supplemental oxygen via non-rebreathe mask, titrate down to flow rate where they're able to maintain SPO 94 to 98. Okay. Why do we want to maintain saturations 94 to 98? Let's find out. So what my argument is why are we keeping it at 94, 98 if the patient's acutely unwell? Why are we not aiming for 100% basically? So you're at risk of oxygen toxicity, if there ever was a thing. So too much oxygen, free radical formation, which can damage the lung tissue. The principle still applies in asthma, even though the main concern is in COPD. If you flood a patient with high flow oxygen and get them to 100% sats, you might miss rising CO2. In severe asthma, patients can develop hypercapnia due to fatigue and poor ventilation. Oxygen alone won't fix this and can hide it actually. The oxygen dissociation curve, which I'm sure some of you guys might be covering in A-level, is sigmoidal. Above 94%, you're already on the flat part. That means there's no real extra benefit to pushing the sats higher. Tissues are already fully oxygenated, but if you don't want to, we don't want to go below 94%. Okay, so that's literally what they're saying. So we want to correct the hypoxemia, but we're not trying to overshoot, basically. So if someone's thirsty or dehydrated, we want to give them fluid, but we don't want to drown them, for example. It's the same principle. If someone's in peri-arrest or actually arresting, you just give them 100% oxygen via bag valve. But for standard asthma exacerbation, 694, 98, which I think is what they said. So, giving them SABA. So this is your blue inhaler, basically. Let me zoom in, make sure you guys can see it as well. How's that on the stream? Yeah, okay, cool. So we're going to bronchodilate with the SABA. So we want to give them high dose inhaled SABA. So nebulized, I think. Oh right, yeah, here. So patients without features of life-threatening or near-fatal asthma, this can be given by standard pressurized meter dose inhaler, PMDI. So that's the, or by the nebulizer. You know what? I don't think that's how you spell nebulizer in UK English. Look, in British English, right, that's nebulizer, and this says nebulizer with a Z. Okay, now either the writer was American, or this has all been written with ChatGPT. What do you guys think? You know what, I'm going to check the guidelines, because, oh, that's weird. Is it NICE? I know there's NICE and then there's the British Thoracic Society, British Thorax Society, or Thoracic Society, something like that. Oh, right, here, BTS, that's fine. These are the new guidelines as well, so. Recommendations. Management. So the initial management is, so I see, oh no, this is like a new diagnosis, and we want acute asthma. Oh god, what's this? Oh no, my downtime is activated. Oh dear. Screen time. Downtime. Turn off. I hope that still works. Is it still working, I hope? Yes. Okay, cool. Okay, right. Okay, cool. That's still working. Where's the acute? Can we just download the PDF? Okay, right, lovely. So this is all of the asthma guidelines. Just save that there. Let's upload. Using this guide only. Using these guidelines only. Tell me what to manage. For an acute asthma exacerbation. I don't know if I've spelled exacerbate wrong, but oh, there's a different one. God. Alright. Okay, right, so basically, if there's life-threatening, which is, these are the criteria, if there's life-threatening asthma, just give them the nebulized Sava, basically. Corticosteroid, all the patients should be given 40 to 50 mg of PO pred for at least 5 days. So between 8 and 10 tablets if it's the 5 mg. Because I dispense so much of these in pharmacy, innit? So it's like take 6 a day or take 8 a day. Take 8 a day usually. Because then what it becomes is like you need 40 tablets. And obviously tablets usually come in boxes of 28, so then you end up splitting 12 from the one, and then you get all these split boxes, and they're so annoying. But I wish they'd make like a 40 pack. Yeah, because 40 divided by 8 is 5, yeah. 5 days. So continue their inhalers, including the ICS. Ipratropium, or in patients who have not responded to beta agonist or corticosteroid treatment, nebulized IPA, or a SAMA, and then you give IV mag sulfate. So there's a mixed evidence base for this treatment. But I feel like if doctors are giving it, if consultants are giving it, I feel like there's probably some kind of evidence basis around it anyway. It's like it doesn't hurt to give it, so you may as well try it, I suppose. Which is what sometimes a lot of medicine is, like the newer developments, I suppose. Maybe I shouldn't say that. Sorry. I take it back. IV aminophylline. Maybe consider following consultation with some senior medical staff. Aminophylline, I think I've heard of it before. Must be enough. Do you see it in hospital? No, it's all IV. I won't see it in community. Oh God. Okay, I have placement in the morning. Right. Alright, lock in. Patients who fail to respond should be treated in ITU. Okay, that makes sense. Intubation, ventilation, or extracorporeal. Have you seen this ECMO machine? I saw one in theatres once, and they actually look pretty cool. I think you put it in the femoral vein. Yeah, you put a cannula here, and it's basically like the machine basically oxygenates the blood, so there's a big tank of oxygen next to it, and the machine will oxygenate the blood. It's actually really sick. Okay, lock in. So how do you know you can discharge them? If they've been stable on their discharge medication for 12 to 24 hours, if their inhaler technique has been checked and recorded, and if they're, I'm presuming that's perf is 75 or greater of best or predicted. Okay, right, next question. So, 23-year-old woman in the clinic, 4 months of exertional dyspnea, dry cough and wheeze, worse at night and cold weather. She's never smoked, no past medical history or allergies. So I'm thinking asthma. Just because cold weather, and it's a young lady as well. So let's have a look at the labs. Let's not look at the question yet, let's just look at the labs. So she's got normal hemoglobin, she's got normal platelets, she's got normal whites, normal white blood cells, normal neutrophil. What we're looking for with asthma, I think, is like the eosinophils. So her eosinophils are normal, her monocytes are normal. So she has phenotesting, and that's also normal. So I think we're thinking with I think so basically I'm suspecting asthma in this lady, and so I think spirometry is the next thing to do, but I don't know if spirometry would be the next best thing to do, and I feel like that is the answer, but I also feel like if we give her a SABA, that would also be... I feel like it's one of these two. So it's either spirometry with bronchodilator, reversibility testing, or it's start salbutamol inhaler and diagnose clinically based on the response. I think it's one of those. Okay. No phones, guys. That's the whole point of streaming. No phones. Locked in. I feel like the book would want this, but then I feel like I should give her a SABA because she's breathless. But okay. Yeah, legit. yes. If it's not confirmed by the eosinophil count, so if it was raised or if the pheno was raised, then it points towards that diagnosis of asthma, but if we haven't got any of the evidence, then we do the BDR. I'm saying BDR to sound cool, but spirometry with the reversibility testing. So what you should notice is that if this lady, let's say she wasn't 23, let's just say it was a person, and they had like shortness of breath. Spirometry, what they would test with the SABA is basically, is it reversible? So they'd make them like uncomfortable, or they'd make them like short of breath, and then they see if the SABA would help them, and that's like bronchodilator, because SABA is a bronchodilator, and the reversibility, so if it reverses that uncomfort, essentially. Patients with exertional dyspnea, dry cough and wheezing. Because basically Professor Galloway is basically like, the questions that you get right, those are the ones you need to read, because like I could have guessed this question, which I was going off of like a 50% chance anyway, down to those two options. It's funny that one of them was the lowest pick, like that's start the SABA and diagnose clinically, which I feel like, you know what, I feel like if a patient came in with shortness of breath, I feel like the GP wouldn't actually be that hesitant to give them a SABA anyway while they were getting all this testing done. What do you think? Chat? You guys in my chat, what do you think? I'm gonna wait until someone says something. What do you think? Would the patient, would a doctor from your experience like be hesitant to give them like a blue inhaler for their troubles? Okay, thank you. Hannah, what medical school do you go to? Or have you applied to? Nah. Probably not. Thank you, Jahida. Thank you. So you think probably not? Okay, cool. I feel like they give them the blue inhaler basically and just like try and get them off their back, which is what you see in placement, unfortunately. But yeah, so, looking perfect. We can talk about the diagnosis of asthma, which is very interesting. So, guys, lock in, yeah? We're going to explain how you diagnose asthma, okay? In 2024, so November 2024, BTS, NICE and SIGN, I don't know who SIGN are. Scottish Intercollegiate Guidelines Network. So they produced joint guidelines on the management of asthma. Following many years of conflicting guidelines, the new guidelines represent a major step change in the management of asthma. The new guidelines represent a major step change in the management of asthma is both diagnosed. So there should be a how there of how asthma is both diagnosed and treated. passmed. This is literally why James Galloway says don't use passmed as your main revision source, because it's written by like people like me who will have finished med school in like a couple of years, and it's written by like fifth years and junior doctors and like not professors. Like if James Galloway wanted me to, if I wanted to study asthma, James Galloway would tell me to go here. He would want me to go here, and actually let's read it. Respiratory medicine, yeah. Asthma. He would want me to go here, he would want me to go here, sign in through my institution. I go to King's. So he would want me to like read all of this, and you know what, I happily would, because see, that's quite sick, isn't it? So this is the intro to asthma. Asthma is a chronic inflammatory disease of the bronchial airways. The defining clinical characteristics: reversible airway narrowing. So this is what we're talking about with the bronchodilator reversibility. An increased airway responsiveness to non-specific provocative stimuli. So this is where increased airway responsiveness to... I'm just thinking, is it like dust and stuff that can also cause it? Okay, right, so definitions of asthma, which are focused on these clinical characteristics, so the ones listed above. To distinguish it from diseases associated with irreversible airway narrowing, how it emphasise the intermittent nature of asthma rather than the persistence of the underlying inflammation, with potentially inappropriate implications for treatment. So what is A and B showing? So the defining pathology of asthma is desquamative eosinophilic bronchitis in figure A, in comparison with normal histological appearances in B. So this is what a normal squamous cell, I suppose, look like. And then, as you can see here, how do we even compare these? Let's open this up in a new tab. Cancel that. Let's get an explanation from our good friend ChatGPT. Explain what I'm looking at. So ChatGPT says histological images of a bronchus comparing with a normal airway from one with asthma. So image A, the top one. Let's go through the normal one first. So this is a normal bronchial histology sample. This one. So it's got a clear open airway lumen, which I'm presuming is that, yeah. There's thin regular epithelium, which I'm presuming is all of that. Minimal surrounding inflammatory cells and a normal airway wall thickness. It's not thickened like in asthma. Now, I suppose if we go here, what we're seeing relative to that, I mean, you can see that that space is so much smaller than that space, so much bigger than that space. But no, I don't suppose, because I feel like there's more surface area here as well than here. I feel like there's less surface area compared to there. And so now if we look at the asthmatic one, Quick question, does anyone have asthma? No? Alright, do you? Sorry, 1 second, I'm just writing a report. I love this website so much, I love you guys so much. I don't know how to word that. You guys are like my best friends. Alright, lock in. Wait, why is that gone to that? What the hell? Oh, right. I'm just looking at the stream. I kind of watch it back, but I mute it. Just make sure. It's running alright. Okay. So that airway lumen is narrowed. But I'm just trying to understand, what actually am I looking at here? Is this... Is this the actual bronchus or a cell from the bronchus? Oh. Okay, so this is like... It's like one of those things, basically. How do I... It's basically like one of these things. So it's a cross-sectional view of one of those. So I don't know how they got that. It must have been like a biopsy or something, but yeah, no. It's essentially like one of those. So I was thinking it's initially like that or something, but it's actually one of those. So yeah, primary bronchus is the second bronchi. Sorry, bronchi is the plural. You guys are right. So seeing the lumen, the epithelium lining, the surrounding submucosa. So all of these extra are those inflammatory cells. That basement membrane is quite thick as well, if we see compared to that. It's not a single cell and it's not a bronchiole, which would be much smaller than that cartilage. So I think somewhere here we can see cartilage. Maybe it's this ring, or not. Okay. Don't really care about the epidemiology, but let's just get ChatGPT to summarize this. Summarize this, including key features to know, is what I said. Key figures, sorry. So asthma, it affects it's more than 10% of children and more than 5% of adults in the Western world. Don't know why I mentioned Western. I suppose the textbook mentioned Western, but it causes over 100 over 100,000 hospital admissions and around 1,000 deaths per year in England and Wales. The prevalence has doubled every 15 years during the late 20th century, especially in developed nations. Recent data shows plateauing in some countries. So what is the evidence for rising prevalence? There's the Aberdeen study that was done, which showed that there's a 2.5 times increase in wheeze and asthma in children. In South Wales, there was a 15-year gap. Reported asthma. So in 15 years in South Wales, it reported asthma doubled from 6% to 12%, and there's also an increase in hay fever, eczema, and exercise-induced asthma. So, geographic and socio-economic variation. So higher asthma rates are linked to urbanisation and material prosperity. Interesting. In Zimbabwe, asthma is most common in affluent urban children. Is this suggesting like asthma is like a rich person's disease? That's interesting. That's really interesting. Oh god, why is it not? Okay, no, that's fine. So basically, is it suggesting that asthma is a rich person's disease? What do you guys think? Is asthma a rich person's disease? You guys in the chat. You're my chat. Oh my gosh, I can say chat. What do you think? Is asthma a rich person's disease? Not at all. Interesting. Okay. I don't think so. Okay, interesting. Okay, but I mean, I have data here. We have data here that says it summarised it here. West Germany, which from what I remember of history was the better side, had higher asthma rates than East. And in Zimbabwe, asthma is most common in affluent urban children. Higher asthma rates are linked to urbanisation and material prosperity. Interesting, but okay, fine. We won't make that. I mean, no one's made that conclusion. I'm not making that conclusion. Let's see, what are some of the proposed explanations? So there's environmental and lifestyle changes. So there's indoor allergens, air pollution, maternal smoking. Okay, interesting. Modern diets, low in antioxidants and vitamin D and E, and increase in salt. This hygiene hypothesis, there's a Dr. House episode on it. The porn star that was the patient in the Dr. House episode. And this hygiene hypothesis. So let's ask ChatGPT. So is asthma a rich person's disease? So, according to this, asthma is not caused by being rich, which I suppose is a completely fine statement. It's more prevalent in wealthier urbanised populations, especially in the Western world. So in some ways, asthma has become a disease of affluence. Interesting. So severe asthma outcomes like hospitalisation and death are often worse in low-income, undertreated populations, which makes sense as well, I suppose. Let's talk more about this hygiene hypothesis. So essentially, to give you guys an explanation if you don't know what it is. Explain the hygiene hypothesis in a few sentences. So for those of you sitting at home, if you go to, let's see, Jahida says, if you go to poor areas of London like Tower Hamlets or Newham, a lot of the kids have asthma. So basically that's really interesting that you say that, because that's like the urbanised area, I suppose. That is the place that's urbanised. So that's interesting. It's not necessarily the rich part, but perhaps the urbanised part. But when we talk about urbanisation, we're usually thinking of sort of the more affluent sides. Interesting. I suppose you would know more on that area anyway as well. So for those of you who don't know, the hygiene hypothesis, I mean, I'll read it off here. It suggests that a lack of exposure to the microbes in early childhood, due to cleaner environment, smaller families, modern lifestyle. So basically, being less exposed to germs, essentially, is the simplest way to say it, leads to underdeveloped immune regulation, and so it makes the immune system more likely to overreact to harmful substances. And so I think this links also back to the idea that autoimmune diseases are more prevalent in more affluent areas of the population. Children who grow up with older siblings, pets, farm animals, or attend daycare early tend to have lower rates of asthma and atopy. Atopy is basically, it's like allergies and stuff. Genetic predisposition to develop allergic diseases, so like atopic dermatitis, for example, eczema, just a chronic skin condition. So just like your normal eczema. Yeah, what do you guys think about the hygiene hypothesis? Do you agree with it? Do you guys agree with the hygiene hypothesis? Give you guys like 10 seconds if you're going to say something. No? Okay, fine. It's completely fine. Oh, it makes sense. Oh, yeah. Oh, wow. Okay, cool. You guys said something. Okay, cool. Yeah, so, I mean, yeah, it makes sense, exactly, Jahida, yeah, completely right. It makes sense. So the pathophys. So most asthma, let's see, originates in childhood following sensitization of the airways to common air allergens, pollen, dust mites, animal dander, and fungi. Bro, what word is dander? What does dander mean? Flakes of skin, okay. Typically associated with other atopic diseases such as allergic rhinitis or eczema. In atopic children, dermatitis can precede asthma. So there's this one that I think they talk about these, it's like a triangle of asthma. It's like atopy, allergies, asthma, something like that. I think it's called like the asthma triangle. Oh right, okay, so the atopic triad. So hay fever, asthma, and eczema. I don't know why it matters, but there's like this triangle for the atopic triad. So it's like if someone has hay fever, someone has eczema, there's like a higher chance that they'll have asthma. I think essentially. But yeah. This is a whole load of very interesting stuff, I imagine. So this is the interesting bit. So up to a third of asthma patients are non-atopic, increasing to up to half of patients with severe diseases that are non-atopic, and several non-allergenic exposures such as bacterial endotoxins, air pollution, viral infections during early life are believed to contribute to the development of their disease. I think I'm boring myself. I don't know how you guys are still here. Despite normal IgE levels, these patients are frequently found to have eosinophilic airway inflammation. So eosinophils are the ones that we're concerned about with asthma. Despite normal IgE levels, patients are frequently found to have eosinophilic airway inflammation. So, a distinct class of cells discovered in 2010 as neurocytes and eventually named innate lymphoid cells are believed to be responsible for eosinophilic inflammation in non-atopic individuals. Okay. Airway epithelial damage, for example, by viruses, results in the production of interleukin 25, interleukin 33. So these are basically just inflammatory markers. And thymic stromal derived lymphopoietin, which is a word I never thought I'd be able to say, which in turn activate innate lymphoid cells to release interleukin 5 and interleukin 13, but not interleukin 4 for some reason. Thymic stromal derived lymphopoietins and epithelial cell derived cytokine. Cytokine is basically just like a chemical marker that is produced in response to inflammation and drives the allergic responses. Okay, so don't really worry about the phenotype. What are some of the biomarkers that we're looking for with asthma? Asthma is an inflammatory disease of the airways. We know that markers of the airways have been sought for both diagnostic purposes and a guide to measure the effectiveness of treatment. So which makes sense. So we're looking at biomarkers for both. If the biomarkers are in a certain range, we want to be able to know that is concrete for a diagnosis. And once we sort of have a diagnosis of someone with asthma, we want to measure their biomarkers and see how they're getting along for the measurement of, as a guide to the effectiveness of treatment they've written here. I hate respiratory medicine. I hate it. And somehow it's better than gastro. So when we do the gastro stream, I don't know how I'm going to stay awake because gastro is so boring. Gastro is the worst. We're doing resp right now and gastro is the worst. Oh, here we go. But you also inherit immune regulation from parents, so it's probably largely due to genetics too. That's interesting. Let's ask ChatGPT what it thinks about what you said. So from what I think, I don't know. I know that there is some immune pattern with things like rheumatoid arthritis, in terms of genetics. But I'm gonna let's ask the expert actually. Someone said this. That was about, they said it, I believe the whole, about the about the hygiene hypothesis, didn't they? What do you think? How much of it is a genetic part? Okay, interesting. But I'm gonna get a source before we give that statistic. Yeah, I would have thought that environment was a big part of it. Most studies suggest 35 to 70% heritability. So I think there's a big mix in terms of it. So I don't know if we can say largely due to genetics. I feel like we should be a bit careful with that. What do you think? Where's the stream? I think the stream's lagging. I hope it's normal now. My friend's calling me. Let's see what he says. Yo, what's going on, man? Walaikum salam. What did you say? Oh, right. Yeah, no, I'm not on it. Bro, the SFE came, the SFE's gone. Oh, bro, I'd love to. Can we do tomorrow? Inshallah. No, it's not that I've already eaten, it's because I'm studying right now and I've got placement in the morning. Like, literally first thing in the morning. Got that stupid GP, man. Legit. Mine's in Watford. Yeah, but it's like sometimes I hop on because I get a later start. I'm in the second group, so I'll be like, I start at like 10 a.m. And then I leave my house and it's telling me like 19 minutes, and I just don't believe it because I have to get onto. So I leave Yard, get to A40, get on M40, get on M25, and it's literally you ride. Let's say we're like 9 o'clock when we got on the M25, innit? And you have to ride it up to 11. So it's literally just M25, yeah. But yeah, I would love to. Genuinely, I would love to, but I can't. Tomorrow, yeah, hopefully. Believe me, I'm very much looking forward to getting you to pay for something. Believe me. But yeah, yeah, I'll be on Holloway at some point. But the thing is, I just got my setup, so I feel like I can just do it at Yard. Do you know what I mean? And you have to try this new chair. The new chair is so comfortable, bro. If you thought, no way, mate. This is like this chair. It retails for 200. I got it for 40. I bought it from some footballer in Watford. I saw it on Marketplace. Yeah, it's sick. You have to come try this chair out, mate. Honestly. Oh, I just said mate again. I said mate. No, I haven't. No, I haven't. I'm streaming, so I'll watch it back. Yeah, I'm streaming passmed. Yeah. YouTube. I've got got 2 of my students in the thing. Yeah, they're revising and they've just got me playing in the background. Yeah. Yeah, they can hear me, and I think they're watching as well. No, you're on my ear. They can't hear you. Alright. Alright, take care of yourself and speak to you soon. Alright. I'm gonna check if I've said mate. I love you too, man. Alright. Goodbye. Bye. Allah Hafiz. Allah Hafiz. Bye. Bye. Alright. Sorry about that. Yeah, Jaheda, I do feel like you overshot with the wording, with largely. Yeah, partially. Great. I mean, as long as we all learn a lesson, you know, that's what it's all about. I think we'll go to 1. We'll go hard to 1, and then we'll assess the situation at 1. Okay, right. So recent studies indicate that if both parents have asthma, the child has approximately 50% chance of developing the condition. See, this is why you always have to double check this loser. We're going to get a source on this as well. %, 35 to 95%. Okay, interesting. I like this explanation that I said here. Genes load the gun and the environment sort of pulls the trigger. That's very interesting, because we don't know how its aim is. So it could shoot at a very critical part, like it could be very high intensity, and could also not. Okay. Cool. So, inflammatory diseases, the airway markers of airway inflammation have been sought both for diagnostic purposes and as a guide to the infectious treatment. Yeah. So, currently, sputum, so spit, mucus, eosinophil counts, and measurements of FeNO, fractional exhaled nitric oxide, can be considered useful tools in identifying specific asthma phenotypes. So what are some of those asthma phenotypes? The early onset allergic type and the late onset eosinophilic phenotype are both orchestrated by Th2 cells. They're clinically distinct yet overlap immunologically. Th2 cell signature is also predominantly seen in exercise-induced asthma. Let's just check what are the... So atopic asthma, non-allergic asthma, childhood onset asthma, late onset, so I think that's the one that... Early onset allergic and late onset eosinophilic phenotype both, okay. Okay. Boring, an increase in the sputum eosinophil count is an indicator of reversible airway narrowing and is associated with corticosteroid responsiveness. So a raised eosinophil count is associated with corticosteroid responsiveness. Bro, I'm legit yawning like every 3 minutes. This is so bad. I don't even have any caffeine on me like that. We'll have it for the next stream though. Come on. I hope you guys like the stream. You know, last 15 minutes of the stream. So management of asthma with the additional intention of decreasing the sputum eosinophil counts to normal has been shown to reduce the frequency of asthma exacerbations. Okay, interesting. I really want to see if they say anything about magnesium sulfate here. That would be interesting. So pheno, fractional exhaled nitric oxide, is increased in patients with asthma. It correlates with sputum eosinophilia, particularly in steroid-naive patients. So patients that I think it's basically saying that patients that haven't had steroids before. What does this mean in one sentence? Because it'll just long it out if I don't. So individuals who've never been treated with corticosteroids inhaled or systemic before, yeah. So it's basically saying pheno is increased in patients with asthma. It correlates with sputum eosinophilia, particularly in these patients who've never been treated with steroids before, and it's reduced by treatment with inhaled corticosteroids. So beclometasone, what's some of the other ones we give? Beclometasone, the ones that are inhaled. I'm just thinking, beclometasone we definitely give, that's the brown inhaler. Inhaled corticosteroid inhalers, BNF. Let's check the BNF. So it's literally beclometasone, like Clenil, prophylaxis of asthma. What's some alternative? Is there like an alternative section? No? Two minutes that time. Let's check like beclometasone. Let's check betamethasone. So betamethasone is also a glucocorticosteroid. We're just gonna check if it's like. See, look, none of these are inhalers. Let's check mometasone. Oh, there is a mometasone inhaler. What the hell? Which one? Medicinal form, inhalation powder, Asmanex. Bro, legit, like, I've never seen this before. Asmanex. Let me see a picture of it. Nah. Oh, actually, maybe I have. It's so dead. So let's check clobetasone. So Humavate. You guys must know Humavate. No, not E. Clobetasone. So clobetasol is here. That doesn't come as inhaler. Clobetasone, butyrate, indications, and dose. So here it's used as eczema. Medicinal forms. See, no, it's not going to it. Beclometasone. If we go here, does it give you the little section for inhaled ICS? Bloody hope so. Yeah, so you see, you get all of this shit, inhaled solution, pressurized inhalation. Okay, right, last 10 minutes, pull through. Oh no, that's beclometasone. Yeah, beclometasone. Yeah, that's the one in Clenor. What else? Betamethasone, memetazone, fluticasone, furoate. Oh, it's here as well. Medicinal forms. What is this one called? Oh, I think this is just I think it's no. What is it called? It's Seretide. I think this is Seretide. Let's check. Seretide or Flixotide. Flixotide or Seretide, I think. I think it's Flixotide. Let's check medicinal forms. Pressurized inhalation. Yeah, Flixotide. Wicked. I knew it. I think salmeterol is Seretide, but yeah. Okay, right. Let's get back to where we were. So it's reduced by treatment with ICS. However, the range of FeNO in the normal population overlaps with the range in patients with asthma, and FeNO is a less good discriminator between. So basically, sputum eosinophilia is better at discriminating between non-asthmatics and asthmatics, so it has a higher sensitivity, I think, is the right term, or specificity, one or the other, right? Learn the difference. If there's one thing that I guarantee you should commit to memory, is the difference between specificity and sensitivity in these sort of drug trials. Should say partially. Do you think I'm wasting my time by reading intro to clinical examination now? Yeah, probably. Okay. Digress. Sorry. It took me 10 minutes to look at it. What's the chair called? It's a GT Omega. OASE. And Mick, do you think I'm wasting my time by reading intro to clinical examination right now? Yes, I think you are, but it's not going to hurt you per se. I don't know if I'm lagging or not. I hope it's alright. Am I lagging? If you guys tell me, and then I can tell the story. Someone say something, anything, please. Oh, okay, brilliant. Okay, right, thank you. Okay, right, so do you think I'm wasting my time by reading intro to clinical examination now? So these are like your cardio exam, your A2E exam, your resp exam, abdo, gastro, gynae. These are like stuff that you will pick up on the job, and it's best to see it done by someone else. But you know, an intro to clinical examination is like the idea of what is involved in clinical exams, and so it always comes back to the initial people skills that you need. So having that ability to communicate, having that ability to build rapport with the patient, that's something that you can work on, as opposed to reading that specific clinical examination. It's like you picking up a book on like a 5th year exam, like I don't know what your curriculum for the school that you're going into is going to be, but if they've got OSCEs in first year, then yeah, I'd say like you can read into clinical examination now. But I've had my first OSCE in the end of my 2nd year basically, and it was formative, so I don't really, like I went in and I literally flopped it. I think I talked about it in the newsletter how bad my OSCE went. And that's not to like discourage you. I'm not saying, oh, I did a shit OSCE, so I want you to have one as well. It's just like it's not worth stressing over yet. So if you start thinking about it now, it's something that will come naturally to you with exams. Like you will learn the order, but the way that you are assessed with OSCE, it's a bit like a song and a dance that you have to do with the examiner. So be wary of that. But I think I think there is better things that you can do. When you say wasting your time, it sounds a bit harsh. There are probably better things that you could be doing right now, like building a good solid foundation on your biomedical knowledge, your base knowledge, basically. You could start working on your anatomy, your physiology. But I mean, it is interesting the way that we do it. There's a really good book. It's called On the Origin. Oh no, you can't see this window. There's a really good book, and it's called, I think it's On the Origin of Modern Medicine by William Osler. This book, if you want to read a book that really will explain to you the William Osler. If you want to read something, read this book. I think it's one of the best books. Like I read it when I was on my gap year. I think it's one of the best books ever. So The Origin of Medicine, for example. Where is it? There's something here where it talks about like sort of the first exams that we ever used to do. It's somewhere. Control F. Auscult. So auscultation. So this is where it mentions auscultation. So here, the examination of a patient had largely been by sense of sight, supplemented by that of touch. So this is what you look, have a look, have a feel, have a listen. It's kind of the principles of clinical examination. And you see here it talks about sense of sight, touch, and estimating the degree of fever, the pulse. Inventum novum, so the new invention basically of percussion. Recognised by Covisart extended the field, but the discovery of auscultation by Laennec. So this is have a listen, publication of his work, Mark's Near in the Study of Medicine. The clinical recognition of individual diseases had really made little progress. So this is the first time they sort of used the stethoscope. Physical diagnosis, clinical pathology of the heart, lungs and abdomen. So we're listening to the heart. And so here, I think Osler's saying that Laennec's book is in the category of the 8 or 10 greatest contributions to the science of medicine. So it is really interesting when you think about how all this started, because there's always guidelines to follow initially. I read extracts of this. Yeah, read the full book. I haven't read the full book. I've read like the first few chapters, but I think it's literally one of the best books ever. And it really, the origin of medicine, it is like the reason why we do what we do. It's the reason why certain things stay in place. It's where I learnt why surgeons are called Mr. and Miss instead of Doctor, because well, I mean, I'll let you guys read the book to find out why. It's really interesting. Yeah, no, I think read that book. That is an excellent book. So read it for, I mean, you read extracts for your EPQ, but read the book properly. So yeah. Is a really cool book. I can't do it justice, by telling you enough, but it is a really good book. But yeah, I'm going to leave that open actually. Okay, right, so let's try and get this finished quickly, and we'll do one more question. So there's inducers and provokers when we're thinking about. Let's just summarize this quickly. In a few lines of provokers versus inducers. Let's see what it spits out. So the provokers: exercise, cold air, histamine, methacholine. It's funny that methacholine is actually what induces bronchoconstriction when we're testing for reversibility. So these trigger acute transient airway narrowing. So these are the provokers, so they make the airway narrowing worse. They do not increase the underlying inflammation, and they cause reversible symptoms that are resolved quickly. So the provokers are sort of like short term in that way. And the inducers, so if you think we're inducing something, we're increasing something. So these are allergens, viral infections, occupational chemicals. They worsen the underlying airway inflammation, and they increase airway hyperresponsiveness. And these effects are a bit more chronic, so they're lasting days to weeks, making the asthma harder to control. And they can provoke immediate and late phase responses and increase sensitivity. So an inhaled allergen is a sensitized asthmatic. In a sensitized asthmatic, immediate bronchoconstriction and a late inflammatory response. Yeah, that's fine if that makes sense. Let's just do one more question quickly, and then you guys have my permission to go. If we get it wrong, it's going to be so awkward. But alright, fine. We go in, we're ready to get the question wrong. Okay, so 25-year-old man, he's got his asthma review in the GP, I presume. He's taking the brown inhaler, and he's taking 100 micrograms, 2 puffs twice a day, and he also has a SABA. His asthma control score is 25/25. I think what we're doing here is, I think we're weaning him off the steroid. We don't want to take him off straight away, so I think we're just going to reduce it by 25-50%. Because I think if his asthma control test is high, I think that means that he's controlling it quite well. Could be the opposite. It's the first time I've seen this score. First time I've ever heard of the score as well. So, are we going to add in a LABA? Probably not. Are we going to add in an LTRA? Probably not. Don't think we're going to double it. I feel like stopping makes sense, but I feel like reducing it makes the most sense. We're still going to want him to be able to use the blue as required. And yeah, hopefully that's right. Yes! Okay, cool. Because he's controlled his asthma basically, it's at a point where we can start to wean him off the steroids and see if he can handle that. And if he can't, then we'll put him back on the normal dose or increase if necessary. I think you can go to like 250 twice a day, 2 puffs of 250 twice a day. So actually, let me check that before I say that to you guys. Beclometazone. Just very quickly. Beclometazone. Indications and dose. Prophylaxis. Yes. So you can go up to 800 micrograms twice daily. So 250 twice is not that bad, I suppose. Right. Okay. I think that'll be enough for today. Thank you guys so much for coming. Yeah. If you guys want to say goodbye, you can. I'm just gonna give it a couple of minutes and then I'm gonna turn off the stream. Thank you guys so much for coming. I hope you enjoyed it. I hope you learned something. If you didn't, that's fine as well. Yes? No? Anyone there? Okay, right, well, I'm gonna try and go to bed now anyway. So yeah, thank you guys so much. Hopefully, I hope you guys can still hear me. But yeah. Oh, great. Yeah, thanks. Thanks, Hannah. Alright. Okay, have a good night, guys. Oh, thanks, Jada. Yeah, not a problem. Not a problem, man. And Oasis, I presume, is there as well. Okay, right, good night, guys.